The following audio-supported podcast is intended for informational and educational purposes only and is not intended as medical advice. Please speak to a healthcare professional before making any treatment decisions. The guests on today's show were paid to participate in this podcast.
What's up, Chico's listeners? It's me, Dr. Z.
And me, Dr. C.
Dr. C, we've got a really good one. Actually, I can't remember the last time we've had a panel with so much star power.
I don't know if we ever have.
Yeah, this might be a new high for us. We have
a good topic.
We do have a good topic. We're live from Stowe, Vermont. We're here for the NASCC meeting, and it has been a really good week.
It really has. I am so impressed by this meeting.
Yeah, I mean, it's definitely blown away my expectations. It's great to catch up with old friends, meet new friends. And our superstar panel here probably doesn't need an introduction to the sickle cell warrior community.
No, I think these will be some familiar faces to everybody, but
for sure. We've got a couple Cheat Code alums as well, which is kind of cool. We've got some new guests to Cheat Codes, which we're very excited about. So with us today are Dr. Payal Desai, Dr. Seethal Jacob, Dr. Pat McGann, and Dr. Andy Ellner. Welcome to Cheat Codes.
Agios is a biopharmaceutical company that's fueled by connections with patient communities, healthcare professionals, partners, and each other. Building on these connections and the company's unmatched leadership in PK activation, Agios is pioneering therapies for rare blood disorders, including PK deficiency, thalassemia, and sickle cell disease. To learn more, visit us at agios.com. That's agios.com. To join the conversation with other patient allies, follow us on Instagram at Ally Voices Rising. That's Ally, A-L-L-Y, Voices Rising.
So we've got a really interesting topic today, guys, and we thought, one of the sort of ideas that's, nebulous, but probably shouldn't be nebulous is, what is good sickle cell care? What does that actually mean? And understanding the intentions with which NASCC was created and why you all come here every year to have, meaningful, maybe contentious discussions sometimes on how to manage sickle cell disease. We thought it'd be a good idea to get you guys in a room and talk us through sort of your guiding principles on what is good sickle cell care.
So you're going to start with the adult provider, which is probably, I think, at least to me, is a very tricky space. I think that good sickle cell care for the adult is about meeting the patient where they are. And I think great sickle cell care looks like a comprehensive care model where you have integrated experts in their own respective fields, all working together to give care. So at my first job interview, they said, if you could wave a wand and you could have the most ideal care, I said, I want to use the cancer multidisciplinary model. So you go in for a cancer visit. If you've got breast cancer, you see your radiation oncologist, you see the surgeon, you see the oncologist.
Yeah.
All in the same space at the same time. They talk about the case beforehand.
Sure.
And they know exactly what they're doing. When they walk into the room, they already have at least somewhat of a plan that they're looking at. I don't think we're quite there yet, but that's what it would look like to me. You have your nephrologist, you have your cardiac specialist. So that's what great care looks like, along with an infusion space 24/7. So I have my wand. Are you ready?
So Dr. Desai with her wand, for the warriors who don't know, tell us kind of where you are and what your affiliation to sickle cell disease is.
So I am at the McGann Cancer Institute. It's Advocate Health now, and then we're part of Wake Forest. So with the new Wake Forest Charlotte Med School campus, and we have components of what good care looks like, I think. Comprehensive care, so where the hematologist does a quarter of the pie, but then we have a psychologist and a pharmacist and social work and an educator, all helping the patient really achieve what they want to achieve in their life.
I love that. Dr. Jacob, let's go to you. Does that resonate what Dr. Desai is saying?
Absolutely. I think it's true in pediatrics too, right? So good care or great care is being able to deliver the care that individuals need in a way that they want to receive it, right? At the end of the day, that's everything that NASCC and all of us are trying to do is we're trying to take what we know is important for their health and good outcomes and trying to provide it in a way that is acceptable, is easy to access, and is complete and comprehensive. And so all those things that Dr. Desai mentioned are still things that we want in pediatric care, right? The co-location of specialists to make it easier for our patients and families, because it's a lifelong disease, and that's a lot of time spent with us and our medical teams, and how can we improve that time?
Yeah, I think that's such a critical point. Is like, what do patients want? How do they want to receive their care? That's such a critical point. Our lifespan hematologist.
Well, technically a pediatric hematologist, lifespan by default, I guess. But I learned a lot. So I'm a pediatric trained hematologist, only took care of pediatric patients for the first 10 or so years that I was doing this. And then now for the last 3 or 4 years, take care of both and get a lot of perspective of the adult world. And I'll challenge a little bit Dr. Desai that they're different, that we have a good care for an adult is different than a good care for a child. I think the good care for pediatrics and adults is the same. And it's what you said. It's meeting the patient where they are and giving them their needs and giving them a good life, giving them a good quality of life, really. And I think that requires a lot. And NASCC has certainly stepped up and described what that was. I think before NASCC, at meetings like ASH and others over time, these meetings like this were only doctors. And this meeting has so many different specialties, pharmacists, and advanced practice providers, and community health workers, and clinical social workers, and psychologists, et cetera, et cetera. And these people are essential. We can't do it ourselves by any means. We're like the least important person many times. So I think you need those people to address all their needs at the end of the day to give the patient a better quality of life.
Very interesting. Dr. Ellner, your perspective on good sickle cell care and your affiliation to sickle cell disease.
Yeah, I feel like I'm a little bit of the ugly duckling on the panel here. I'm actually a primary care doctor by background, not a hematologist, and mainly a digital health entrepreneur at this point. And I'm founder and CEO of a company called Quilt Health that's building a software platform to help to accelerate access to transformative care for complex conditions, starting with sickle cell disease. Before that, I built a company that is in 50 states delivering virtual primary care and a health plan offering. And I came into this space inspired, honestly, by the potential for technology to just support the incredible work that these folks are doing.
Very cool.
Have been really inspired by the NASCC community, which we're lucky enough to partner with. And so to address what is good care, what's inspiring is we now have this community that's defining what best practices are, recommendations for the way care should proceed. We're really excited to build technology that supports these care teams to, frankly, just follow the guidelines, follow the recommendations. We've seen opportunity to support teams in a couple key ways. One is around just supporting data access, basically. So helping to pull in using software and artificial intelligence, that kind of comprehensive data-informed picture of what's going on with a patient. And then by having that data in one place, you can then start running the algorithms of, what does this patient do for, according to NASCC consensus recommendations or ASH guidelines or other guidelines. So how do we support the clinician to deliver evidence-based care? And then can we start supporting patients and caregivers and others in the community outside of clinics to, have access to the best, the right care at the right time, following guidelines, access to transformative therapies, things like that.
Very cool. Very cool. That raises an interesting sort of issue in my mind, which is we're talking about good care, sometimes delineating outpatient and inpatient care is it's almost like two different diseases, right, that you're managing simultaneously. So what I've heard from you guys so far has been very focused on outpatient care.
Yeah.
Talk to me about like that dichotomy of how you think through. I mean, it's one battle to generate good outpatient care. It's a completely different battle to generate good inpatient care. Talking through that difference.
So I think inpatient care that really is patient focused, I think, is what we need to think about. We need to have people in places that they can have consistent care. So care plans that help patients, because there's so many people involved in that care. So care plans that help people at least start on the right pathway to success when they're coming in with pain. They don't need to have to recreate the wheel over and over again. Most of our patients know what works for them. So, and then the ability to recognize when a pain crisis is complicated or uncomplicated. So what other things are going on and how do we address that? So not only do you have a care plan, but then how does one kind of adapt that care plan? What does that look like when the patient is maybe having some other complications? Who recognizes that they're having an acute stroke? What happens to that patient that's getting sicker?
If I could just add a little bit from my perspective, one of the things as someone new to the sickle cell world, but primary care doc at heart, is when you see people transitioning between different sites of care, or I think in sickle cell disease, when people don't have a lifespan clinician, so they're transitioning from pediatric to adulthood, there's all these challenges around information transfer, basically. And, many folks with complex conditions like sickle cell disease have a lot has happened to them over time in complex ways. And so, we see opportunity to leverage technology to really support that information transfer, essentially, so that really good summary of the patient follows the patient where they go, rather than, each time they see a new provider, someone's piecing it all together, often in really high acuity situations where there's a lot of risk and, issue for not getting, the right information about transfusion history or things like that. And so we're, we think technology creates a real opportunity to support some of these transitions that I think have been really hard for people historically.
And transitions inpatient to outpatient as well, right? So there's the transition over time if there's not lifespan care, but also just what happens in between. So we did home visits for a while. So patients would be discharged and we would go out to their homes.
Oh, wow.
And what we found is more than 50% of the patients had they had a mismatch between what was supposed to be their medication regimen versus what they were actually getting or taking at home. Or like a patient that had seizures in the hospital couldn't get approval for the anti-epileptic and never got it when they got home. So those things that look like transitions of care, and you get there and you're like, wait, what? You're not taking this medication? They're like, no, I couldn't pick it up. So there are real opportunities to improve those.
So I'm hearing this from the adult side. Dr. Jacob, I'd love to hear, do these types of gaps exist in pediatric care as well, or is it better?
Yeah, I think we have the potential to benefit from the fact that pediatrics tends to be a little bit more centralized than adult care, right? We, for example, are one institution, our sickle cell clinic, our ED, our inpatient, it's all together. But I think kind of what everybody is saying is there's still this importance of continuity.
Yeah.
It needs to feel continuous for the patient, for them to feel like they're receiving the care that they want and need. And so bringing folks to the table, but really helping everyone from, the providers in the ED to the bedside nurses to our sickle cell team to recognize that we are all part of this patient's care team. We might just be part of their care team at different times. And how do we make that patient feel like things are not disconnected? And I think that's the key, right? We have to make this feel continuous for both us and the patient throughout all of it. Yeah. Otherwise, it's very easy for patients to sort of get lost, especially when you think in pediatrics, you're moving from really young infants or kids, but we're also taking care of older adolescents and young adults, and the way in which you care for them changes, right?
Right.
And so I think that continuity is really important.
Yeah, I'm struck by that adjective of continuous. Like, continuous care is such a good way to put it, and I feel like it's such a hard thing to implement.
Yeah.
And on top of that, like, who owns that continuity? Is it the sickle cell physician? How much of it is on the patient? How much of it is on the community partners? It's a very complicated thing.
Yeah, I think it's on us, or our teams, our extended hands that are parts of our teams, because I think at the end of the day, we are the ones that care the most and are most invested in our patients. And I think if we're looking for primary care physicians, but it's often challenging, even if the problem is not directly related to sickle cell. We manage a lot of things that are not necessarily hematology or sickle cell related things, but we do it because nobody else like does it for those patients. That has to do with a lot of things related to trust and continuity of care and other things. But I think it's on us to try to help create that communication and continuity.
I'm sure too you all have this experience where the patients trust you. They know you from clinic. They go into the hospital and they really want to know, does Dr. McGann know what's going on here? Did he approve of what you're doing? Because I don't know you. When you know what you're doing.
Simple things like connecting with the team who as I've been a new institution, I'm communicating with inpatient adult hospitalists who I might not know, but I see my patients admitted and I can give some comments even if I'm out of town or here or wherever. And if they communicate that to the patient, the patient is aware that like, okay, we're in the same loop here. Like it's not just a different team. And those little things I think are important. Trust is so important.
It is, but I think the other idea, I think you mentioned it a little bit, the going from my patient, whom I will gladly own 100% to our patient, also changes a little bit of the care delivery that they get. So frequently, if I get a patient call and they're like, your patient is here. I'm like, oh, you mean our patient? Got it. But that's because the model should be our patient, because if they see them as not theirs, then the care that they get is not what they will give to their own patient. So I think there's a little bit, I want them to check if they're going to give them a transfusion, but I also need them to take some of that shared care, because there's so much that happens to our patients, and we can't, unfortunately, even with vast extended teams, do everything 100% of the time.
Yeah, it's funny because this reminds me, there's been this, in the history of primary care, there's been this question, what is primary care? And, people tend to think, oh, it's a doctor or it's a clinic, but the smartest people who have thought about primary care have basically defined it as a set of functions. They've said it's care that is delivered in the context of the family and community, that provides access, continuity, longitudinality. But I think the reality, I think where we've sometimes gone wrong in healthcare is we've defined care around either doctors or types of providers, and sort of organize it in that way rather than organizing it to accomplish the, I think what you were saying, Seethal, about the more of a seamless experience for the patient, and addressing these functions. And that's where, I do think it's a bit of a frame shift in our mentality about, yes, we feel a lot of responsibility and ownership as physicians, but the reality is even, patients and families and, community-based organizations and others are all part of this team. And then what we think a lot about at Quilt is how do we use technology to connect all those people, and accomplish those functions of continuity and these things that actually make for not just kind of good care, but good experience for people.
So we've been pretty kind of hand wavy so far about good care, and kind of we haven't been granular. I know it's probably driving you a little bananas. So let's get a little granular here. There's this idea that good sickle cell care means that your patient's not been admitted to the hospital with a VOC. Well, that may be true. Is that the whole story in sickle cell disease? Is that good care? Is it just my patient doesn't get admitted with pain?
So I think that we focus so much on pain that we miss the entire bottom half of the iceberg. So we've taught sometimes an entire generation of patients to, and this is going to sound funny, but hear me through, that compassionate and appropriate sickle cell care is pain management. And we've equated the two to each other. And while I think pain management is a big part of what we do, if they're not feeling symptoms, it doesn't mean they don't exist. So all of these things are happening on a daily basis where the red cells are breaking down, where they're developing, vascular occlusion that they may not feel pain from, or even the vessels are getting small, they're decreasing flow to certain organs. And I think until we address the multifaceted part of sickle cell care, until we start treating the underlying pathophysiology, a lot of what we do is put a Band-Aid on the symptoms after they start.
Yeah, sure. So, Dr. McGann, you look pensive.
Yeah, we've talked this long. I think hydroxyurea can be inserted into the conversation.
Well,
At least you waited.
Yeah, I mean, hydroxyurea is really, the primary thing we have now, but it's about, so I think differently, in our pediatric patients, we want to prevent anything from ever happening to them when they're 2 or when they're 22 or 52. And when you see adults, a lot of things have happened that you really just want to slow down and stop any more progression. And so I think modifying the disease is the fundamental part of all that we do. And that'll lead to being out of the hospital and quality of life and organ damage that's less severe. But I think controlling the disease, and I think Dr. Desai is spot on, that a whole generation of patients treating the disease was really only managing the pain. And then now we have a generation of adults that have a lot of chronic medical illness because we never managed their disease. And I think, I joke about hydroxyurea, but whatever medicine it is that controls the sickle cell disease, that's what we need to really focus and have as a fundamental aspect of the care. There's not a lot of other diseases where you don't have disease-modifying therapy that's used for everybody, and I think we just need that.
No, it's a really good point. We talk a lot about sort of the disparities that exist in sickle cell disease, both now and historically. And a lot of times we talk about lack of therapies or lack of access. But one of the disparities that I think about a lot is just the framework in which we think about sickle cell disease, right? Thinking about it all from the point of view of this acute complication of horrible, excruciating pain, but not thinking about it from sort of the lens of this is a chronic disease. And as a chronic disease, we need to think about preventative treatments that can modify the disease and prevent these complications from ever happening. And I think it has to be a shift, right, in sort of how we counsel our patients and families, but also how, as a community, we talk about sickle cell disease and we talk about what needs to be emphasized for the lifespan, really.
Dr. C.
Yeah, what are some of those things? Like, what are the outcomes you're trying to prevent, or what should we be monitoring? Should it be how many people are getting offered hydroxyurea? Should it be how many people are getting renal disease? What are the sort of, as you shift from acute pain to preventing complications, what are the complications we're trying to prevent, and what should we be measuring to make sure we're doing that right?
All of them.
I'm glad it's for all.
Yeah, the brain with the eye.
It's a long list, yeah. As a pediatrician, for me, I'm thinking about the brain.
Yeah.
Right? These are developing children who want to be active adolescents and young adults who have sort of plans for their own lives. And I need to do everything to help protect your brain as much as possible so that you can do whatever it is you want to do. And so that's, why we talk about disease-modifying therapies so much. That's why a lot of time that I spend is focused on, the disease you can't see and the complications you can't see, but that will have long-term impact for you.
Yeah. I was just going to say, I'm new to this field, and so just excited always to learn from folks. But some of the exciting conversations I've heard this week is around measuring function. Basically, how do we ensure that people are thriving just in their day-to-day lives? And that feels like the end goal of what good care should be establishing. And it sounds like we're beginning to start to define what that looks like and using that as an outcome that matters.
No, I think maybe starting earlier with some of the screening things and by that I mean some thoughts around trying to do genetic testing on patients so they don't ever develop those LO antibodies so they can get blood, looking at what their retinopathy risk, who goes on to develop retinopathy, and how do we measure that over time. Yes, we have annual exams, but there are now ways to just take pictures of the back of the eyes and monitor that over time, right? And I don't know that we're doing as much of that sort of work, but I think it's an excellent opportunity to look at some of those things beyond the cardiopulmonary, renal, bones, all that stuff that we do.
Is the tide shifting with patients as far as, when you have these conversations, does the patient community grasp on to sort of the thoroughness that's required to monitor actually the damage that's happening in their body from sickle cell disease? Have they kind of bought into that, or is it something that's clear to them, or is there work that needs to be done still to ensure patients fully understand what sickle cell disease is doing to their body?
I think both. So I think some patients I do, and I think it's much more awareness than there used to be. And I think, but there's plenty of work to be done. There's always work to be done. There's been like a paradigm shift in sickle cell care. Like when I talked to my parents who just got diagnosed by newborn screening, and I told them, like, if you typed in sickle cell in the internet, like, I don't think any of these things are going to happen to your child, because it's like different if you're born now in 2025, but all the things we do versus if you were born in 1985. Yeah. And so I think it's like a different disease when you treat it. And I think talking about that leads to conversations about screening and keeping all of these silent things from happening. So I think we're getting there, but certainly lots of ways to be done.
I have a question. When do you shift that from the parent conversation to the patient conversation? Because you teach all of these things to the parents, but sometimes when the patients show up on my world, maybe they have heard these things before, but maybe they don't hear enough of it. And part of it is you don't want to scare them. Yeah. But you also, I think the problem is when you're 20, you're invincible, except with sickle cell, you're not. And so how do you shift some of that conversation? When do you shift it?
Yeah, we're pediatricians. We're kind of wimpy sometimes, but transition.
Dells, no.
I'm very wimpy.
Pediatricians,
but no, I joke. It's transition programs, which are always still a work in progress. Start this education in their teenage years, really, and I think about all of these things, and I think gets a little more serious as patients get older. I do find that I think, despite this, we probably don't say out loud some of the more scarier things because it's uncomfortable to say those things. And I found myself needing to say that to some of our more sick or our more complicated patients who just it's not clicking in their head. And I think they need to hear some of that. So I think it's important to do that. But and I say I don't do it perfectly, but we're working.
Yeah, I would say the same. The psychologist on our team, Dr. Lamont, she's been really great at educating us on how we should educate our adolescents and young adults. So we start now having those conversations when they turn 14, and we kick the parents out of the room and we focus on the conversation with the adolescent. You can't inundate them. One, they're going to tune you out in 5 minutes or less. But two, that can be overwhelming. But I think slowly adding on over time just sort of helps them recognize how complex the disease is, even if they've not been having very many complications, but also just gaining that independence in their care. We actually see it best when we do telemedicine with our adolescents. And parents are in a different room, and it's just me and them on camera or one of my team members. And you can see that understanding and independence develop because it's a one-on-one conversation, really in a way that teens communicate, right? They communicate on FaceTime, on text, not like in a clinic room on a doctor's table with you hanging over them, right? So we have to think of it as the long game. Nothing's going to happen overnight.
Yeah.
Do you remember we used to give quizzes to everybody?
Yeah, they were
Oh, they greeted them so much.
Oh, you see. some of the teenagers would do much better than their parents. Sure. Like, and I think the internet, they had access and they were motivated, and I was always.
I don't know what those quizzes were. I had a patient who was treated in your clinic, and so we used to take these quizzes that were. So there's probably a middle ground between education and what is for everyone else.
I'm glad that you guys are the ones that are in charge of how care looks now, because clearly we were missing the mark with these quizzes. Dr. C, I mean, listening to these guys talk about what good looks like is just filling me up with a bunch of different ideas.
Yeah, I was thinking back to, 15 years ago, there were a very small number of places where sickle cell patients could get quality care. Most of them were pediatric centers. And being at NASCC this week and hearing from our guests today, it's great to hear these multidisciplinary teams that they've built, that they're new centers really over the last few years, and there are so many more of these centers. I do wonder though, I mean, you're starting to build up the standard of care, and I think we've had things like TCD screening as standard of care. How do you translate these things that you learn and you make new standard of care into things that are actually getting done and follow that? So I'll be interested to hear how you guys do it at your center, but also how do you get your colleagues to all agree on what should be done and then make sure patients are getting it?
And you need to track the data. You need to look at it and track it. And I think, it needs to be transparent. I think there's a couple of graphs from articles I show that look at TCD screening over 10 years in a couple of states, and it's a flat line, not because we're not good at it, but because no one's ever tried to notice that we're not doing well. And I think we're getting better at looking at the data. Like U.S. News and World Reports now has some sickle cell metrics. CMS has been discussions at least of including some sickle cell metrics. I've talked to my hospital about including these into dashboards that they have. So we have a really good dashboard where we look at these data and know how well we're doing. You need to see it to know how bad it is or good it is.
Yeah.
I also think we were in the iron session earlier, and I told them that I think all of us should get grades. Going back to your quizzes. But I said, we don't have to share with others. Our report card can be our own. But if you have the National Alliance, you have Granddad data. If you look at the larger, or again, if you're looking at places like Quilt, you can see your own. How are you doing in terms of maybe you're really neglecting iron, right? At your center, you're just not focused on it. But until you see your data compared to others, you don't really know how well or how poorly you're doing. Right. And we're all grade driven, aren't we? We've been taught.
Yeah, it's an Indian subconscious. Right. What is my grade?
But how did I do?
Before you start beating yourself up too much, though, this is, for me, is a really familiar problem from primary care. We're trying to do screenings basically, and you're looking at population health basis, and the reality is these are totally algorithmic, right? What the work you guys have done at NASCC and some of these other guidelines, we know it needs to happen, and I think where I would say traditionally healthcare sometimes falls down is it's just, let's cram one more thing and expect the doctor to take care of it, basically, and cram it into a visit where you're trying to accomplish 1,000 different things, some of them really complex from an educational or emotional standpoint. And so, I've seen this work in other settings where this is just task management. It's, there are tasks that need to happen. You can surface these tasks both to other care team members, but also to patients and families. And then, hopefully just some of that kind of seeing the work and ensuring that it gets ticked off basically, but it's shared across teams and not just, if I just remember to tell the patient again that they need this, that somehow it's going to get better. You do start to see those metrics climb up. But I think it's, there's a degree of elbow grease, but I think you need to kind of move it out of a visit and out of an expectation that it's just the physician's job to take care of this.
Yeah, it's an interesting point. I mean, that goes back to that idea. Continuous care requires two parties to play together, right? And everybody needs to be on board. I wonder if we do generate these metrics, these grades, do you guys think you could walk into like an administrator's office and be like, look at my grade on iron and like I need resources to like get this up? Is that the ultimate plan potentially?
Sorry to jump back in here, but I think you're going to need more than that. I think you're going to need a way to get paid for better grades, basically. And so, we've kind of seen in other areas, and I don't want to there's a lot to say about value-based agreements or contracting or things like that, but I do think there's potential here. And I think part of why we've ended up with this very reactive care model is we're just paying for visits, we're just paying for tests, we're just paying for emergency room visits. And so if there's a way that you can start bringing revenue to your institutions by providing the best care, which then is going to lead to fewer emergency room visits, fewer hospitalizations, things like that, I think it'll really unlock, it'll really align the financial incentives with what is good care, basically.
Are conversations that happen at NASCC getting back to your institution? Do you bring those back? Do you talk about consensus recommendations and talk about how you're aligning on consensus recommendations? Is that happening?
So I think we talk about it. So for example, we were working on getting our center certified for gene therapy.
Yeah.
So we went through the NASCC actually guidelines to make sure that we had before, as we were going through the contracts and things and our center was coming up and going, we used the recommendations to make sure we had addressed each component and sat down with a group of people. How are we going to address each of these things? So I think they can play different roles. So if you're building a center, you want to make sure you have the components. If you're looking at comprehensive note visits, are they at least part of the note? But I think they do provide a structure for QI work. So if you go and say, I don't think we're doing very well at iron, and I think we could potentially do better, it would be amazing if it was value-based to say, if you improve yourself, there would be an additional, sort of feedback to be able to provide even better care on the next metric you do. But I think even emergency room costs and things like that, some of the highest utilizing patient, at least for us, can potentially generate, if you can help them improve their life and quality, and also potentially utilize that to help other patients. I think there's potentially a model there that could be helpful to that individual patient, but also the larger group. So a cost savings model, maybe.
Yeah. Yep.
So after the first NASCC meeting, myself and my adult counterpart actually went back to our institution. We took the papers that Julie and others had written about what it takes to be a comprehensive pediatric sickle cell center and what it takes to be a comprehensive adult center. And we literally colored in the dots of what we had and showed them essentially a blank white page and said, this is what we don't have and what we need if we want to be a comprehensive pediatric and adult sickle cell center. And then when we started developing health maintenance consensus guidelines, we went back, we took those guidelines, we sort of connected the dots between resources that a center should have and how that translates to the health maintenance guidelines, and then essentially highlighted, here are the gaps based on the resources or the staff members we don't have. So each step along the way, NASCC has helped us have those conversations with our administration in a very tangible way for them. So that's been nice. Yeah.
I did the same with my recruitment. When the request or the goal was to build a comprehensive lifespan center, I said, here's what you guys have. Here's what is needed based on this national recommendations. And if we're going to do this, we got to do it this way. And I think we're starting to look at some metrics years later. And, without really direct interventions, except for building a team just within a very short time, like length of stay, these other resources that we didn't even talk about really in the proposal initially because I wasn't even at the institution, got better. And so I think proving that, and we as a community need to do better about proving the benefits of these things, because that's what's going to drive hospital leadership. They don't probably care that we get a A+ if we...
So I have a sort of a selfish question here. When you guys think about good sickle cell care, talk to me about how you think about clinical trials and how does that fit in to this concept of good sickle cell care?
Yeah, sure. So we actually, when I first started, our clinic was like an unusual clinic space, and there's never enough rooms for how many providers and patients need to be seen, which meant that our patients weren't being approached for research studies or clinical trials because there wasn't enough time. We needed the next patient into the room. So we actually moved our clinic into the research center. Merely because it allowed us, yes, it gave us more space, but it actually allowed us to integrate research as a regular part of clinical care, right? So our families started to become more familiar with our research coordinators, with the conversation of research, what research is, why it's important. It gave us a much easier space to be able to represent results from research studies to our families so they understood what their participation meant. So I think, when we think about clinical trials, we have to understand how it can easily be integrated into the clinical care that they're receiving,
Right.
because otherwise we're just causing another burden or another barrier to innovation, right, in our population. So, yeah.
Yeah, I was going to say a real light bulb went off for me in the last year. We've been interviewing a lot of your colleagues just to try to understand how we could build software to support people and support patients. And at one point, I think it was Dr. Stephanie Guarino said, we really want to be able to offer experimental, clinical trials, experimental therapies, because that's part of what good quality is. And it made me realize that I think the field of oncology has really evolved to the point where there is this kind of integration of research and care, and the standard of care is kind of being able to offer whatever experimental therapy ideally would be the best fit for that patient based on their genotype or phenotype or other things. And it seems that we're kind of in early innings of making that also the case in a field like sickle cell disease. So as we started kind of architecting the software platform and figuring out how to support clinicians and patients, we've really been inspired by this opportunity to support integrated research and care. And if that means, for example, on the software platform, when you're hopefully helping a clinician prepare for clinic, you're also surfacing all the different clinical trials that the patient is a match for, not just at their institution, but other institutions. We see a lot of opportunity there. And then likewise, we'd love to get to the point where we're also helping patients understand, what their options are and making those available to people.
Yeah, absolutely.
Yeah. I think that you talked about this, about integrating this into that clinic space. I think we've had such limited options for sickle cell compared to the rest of other chronic illness. And I think part of focusing on the pain is because that's all people could focus on for so long. We had hydria and transfusions for the longest time. And I'm dating myself just a little bit, but I don't think I've been practicing that long. And that's all that was available when I started as well, right? And so I think the reason clinical research is such an integral part of our care is because we need more effective therapies. It's not optional. It's a necessary part of how we move the field forward for people. And then I think good clinical research care in the space involves the integration of patients and families in the research as partners. I think somebody said that earlier today, is that they're not subjects.
Yeah.
They're not participants. They are partners in care. And I think until we start seeing them that way, that integrating them into good clinical care and good research, it's a partnership, and we have to view it that way.
I'm stealing that. I love it. Dr. McGann, go.
Yeah, it comes down to trust. And I think, historically, there's this false narrative that sickle cell patients don't do research. They don't want to participate in research, which is based on nothing and is embedded with so many of the other inequities within this patient population. And when you embed research, and even if they're smaller studies and they're not, clinical trials with a new experimental med, they understand what research is, they know who your research teams are, and that way when you approach them with a new drug, they'll be more comfortable and more trusting of it. So it's essential for our community, for our field, for the future patients. And to go back to your original question, good care is giving them opportunities for these new therapies, which hopefully are good.
Absolutely. When do you guys introduce the idea of clinical trials? Like, is this something that we're waiting until patients are eligible, or is this something that you do you prep them? Like, hey, down the road, we're a clinical research sort of institution, and that's like a priority for us. So they're going to be approached with clinical trials, or do you wait until they meet the eligibility criteria, you have a trial open, and then have the conversation? When does the conversation occur?
For us, because we do even some registries and things like that, we do a very early conversation that we want to partner to improve care across the continuum, and we want to hopefully be able to enhance care for the next generation and the generation after that. So at times you may be approached for things. You can always say no. It will not impact your care, but you may at times in our clinic be approached for things, and it is absolutely your choice if you decide to participate.
Yeah. We include it when we talk about, here's sort of the therapeutic landscape, right? Obviously, we're talking about initiating hydroxyurea, but here's my informed consent of all the therapeutic options, transplant, gene therapy, why, we may or may not consider it at this time. And clinical trials and research is part of that informed conversation. We might not have anything available right now, but as clinical trials come in, if there are things that your child seems eligible for, we'll talk about it, right? And if you choose to join, great. If you don't want to partner in that study, then that's okay. But I think it's important that we help families feel informed. We give them access to, in Indiana, we have a website about research studies that's put in sort of general population terms or layman's terms, and give them access to that and say, just type in sickle cell and see if something pops up, right? Sure. I don't know how many people actually use it, but it's a resource that folks should have access to.
Absolutely.
Yeah.
Yeah, we do the same, and I think it's the same conversation of here's the therapeutic landscape, and I try to share with them, even if there's not a clinical trial in mind, that, hey, I just got back from this meeting, and we don't have much right now, but the pipeline is good, and these things are happening, and some patients want more information about that, and some just want to know. And I think that way when, 3, 4, 5 years later, I especially have these conversations maybe a little more deeply with those who struggle with current therapies, who might be good candidates. So, and I think that's helpful.
I think it also gives them hope.
Yeah.
I think they're struggling with what's available right now, and you say, yes, but these things are potentially coming down the pipeline, or I went to the meeting and it looks so interesting. I hope this comes up for us and as an opportunity. I do think they walk away from that visit with more hope from that, and they will frequently bring that back up. Is it available yet? Are we starting the trial? Are you bringing that here? And I'm like, okay, we're not quite there yet.
I would just quickly go back to the point about continuity, and I think there may be, I sort of see this kind of pattern where we've organized so much about healthcare around visits, which again is this kind of reactive transactional model of doing care versus how do you create value. And I think as I've sort of understood how clinical trial enrollment happens, it seems that it is also organized now around visits, and so it's reactive. The patients who don't make it to their visits might miss an opportunity, for example, to enroll in a trial. And I think there may be opportunity to augment visits with more of a continuous way of making opportunities available to patients.
Yeah. Dr. C, I feel like we could talk to these guys all day.
Yeah, this was a great panel discussion.
Yeah, I continue to be unrelenting in my admiration for all of you, and thank you for kind of navigating this terrain in discovering and figuring out what continuous great care looks like. We're going to continue to follow you guys on this terrain and watch you guys blaze new trails and leave the sickle cell community completely transformed. I think we're in a really exciting time for sickle cell disease, and I think these are going to be some of the people that go down as the ones who really moved the ball down the field.
For sure. And so impressed with what's happened in the last few years and really looking forward to see what's going to come in the next few.
Awesome.
Thank you. Yeah.
Great conversation, guys.